stretch and bond properly. You know, restoratively, most kids by the age of 9 have had nearly 10 times as much dental care than kids without the problems. So huge burden for care. They're hard to get numb. If we get a kid who comes in and say it's been sensitive, we normally consider that we're not going to get it numb. Because 9 out of 10 times we don't. And you can get the best block you've ever done in your life. You could remove their lip with a blunt fork. The minute you blow air on the 6, you're scraping them off the ceiling. You could extract the D and the E without any pain. So they're really weird. I'm not an anatomist, but there are physiological and anatomical reasons, or neurophysiological reasons why that occurs. There's something about a loop, a neural loop, due to the chronic inflammation and the chronic neural signals going back to the brain. So they're nightmares. So always believe the kid, even though they've got a big fat lip and it's gone quick, if they say it's sore, it probably is. So we take a huge number of these kids to theatre because we can't get them numb. And if you're going to take the teeth out, it's not very nice to a 7-year-old to remove something when they're not numb. So they're sensitive, the kids are often phobic, you know, the GAs aren't cheap, and if it's anterior teeth, they look a bit funny. But as I said, it's not a huge issue there. So what do we ask? Has it been sensitive? Does anything make it better? Numbers are soft. In my practice, maybe 50 or 60% got improvement with stannous fluoride and tooth mousse. But that's anecdote, it's certainly not science. But it's the first thing we do in the clinic is tooth mousse. If you're thinking sensitive, you think, can I get it numb? So rather than being king for a day, you have to think long term, how do I get this tooth settled down, or how do I get this kid out of pain without crucifying them? Because crying and screaming kids is not a great practice builder and not very nice for the child. And then you think, do I need a GA, and am I suitably trained to do work under general anaesthesia? Simple things we often don't think about. You know, is the tooth restorable? You know, is there enough structure there that it's actually going to hold something for the next 80 or 90 years? We take a lot of these teeth out now. Huge number. You know, this looks like an old carious tooth. It's not. It's actually caries secondary to hypomineralisation. And if you look, you see that the existing enamel is actually looking a bit dodgy. The really dodgy enamel's gone. Now, this tooth is stuffed. Dental term, it needs to come out. And you'll try and time that extraction to minimise the effect on the child. And think about compensating and balancing extractions as well. So we spend a lot of time talking to orthodontists about these kids. So more specifically, you're thinking, where do I finish my margins? If you're subgingival on a child, take the tooth out. It's not going to be successful long term. So these are dodgy teeth. What do we do before management? As I said, we tend to plaque them up, have a look at the plaque, seeing where they're avoiding. Often they'll have really clean anterior part of their mouth, and where the teeth are sensitive, the ricotta cheese is back. And you can't clean them because they hurt. So they can be real issues for some of these kids. What do we normally do on the first visit is we try and get some GIC on them, just to protect them a little bit, to allow them to come. But you can't blow air and water on them, so you've often got to try and clean them with a cotton bud or a pledget or a cotton roll and dry them with that as well, because if you puff the air on them, they're through the roof. But we try and get some sort of protective layer over them. And cariologically, they're the areas you look for, because that's where they get white spots. So, I don't know, do you use the 3-tone gel up here? Yeah. Something we've really started to use a lot. We find educationally it's fantastic as well. So, just for those of you who don't use it, young plaque, older plaque, cariogenic plaque. Laurie Walsh invented a beautiful, simple idea, as all the good ones are. He just put some sugar in there with a pH reactive dye. So when the pH drops below, I don't know what it is, 5 or something like that, it goes light blue. Simple ideas are the good ones. So, finishing up, I'll tell you about some reasonably recent research we've done. Looking at remineralisation Not much on the Iraqi study, I've cut a lot of that out. Pre-treatment, can we do things to the enamel to make our restorative outcomes better? And can we infiltrate the enamel? So have you had any experience with lesion infiltration? So a commercial product is Icon, very low viscosity resin that you actually fill white spots up with. So it's something that we've played a little bit with hypomineralisation, not with caries. So looking at Agareed's Iraqi study, I was quite interested in a few sort of esoteric etiological factors. What she found that sort of sparked my interest is that if mum said she felt stressed during pregnancy, she was the child was 4.5 times more likely to have hypomineralised sixes. If the child had lots of ultrasonic scans whilst they're in utero, 3 times. Now these are associations, not causative factors. We don't know about the causation. I've got a thing about soy extract. Soy milk is the worst thing for your teeth you've ever seen. But it's involved with hypomineralisation 2.5 times. Is that because of calcium? They're not getting milk, they're getting low calcium product? I don't know. And birth order, if you're below 6 in the family, and in Iraq there are a lot of big families, this is in Mosul City, your chance of hypomin just goes through the roof. Why? Maybe because you get sick, because you get all your older brothers and sisters' illnesses. I don't know whether you get less food because you're slower at the dinner table. Who knows? I was one of 2 and my sister was 6 years older, so it was never a problem in my family. Salivary characteristics correlated. Poor quality saliva was linked with hypomin breakdown in the mouth. So if the environment was aggressive, the outcomes were worse, which sort of makes sense because it's more soluble and it's weaker. Looking at second primary molars, if mum was ill in the last 2 trimesters, nearly 4 times the chance. The kids, low birth weight, we've known for a long time that these kids get a lot of defects. And if they reported just around birth complications, again, 3 times as much. The enamel's full of protein. The main protein is albumin. And we've just finished a thesis looking at what type of albumin it is. We believe the albumin does not come from the oral environment, it's there before the tooth erupts. So the defect is loaded with protein before it erupts, not with the eruption process or from saliva or gingival cavicular fluid. The enamel's really soft, 57% change. So that's one of the reasons why it doesn't work very well restoratively, because you're often trying to bond to marshmallow. Content is decreased markedly. This is some of Felicity's and Nathan's work, but sometimes that you get marked decrease in mineral content. Down to nearly half. It's variable. So this is a cross-section of the tooth. You can see there's marked decreases in mineral here, down to 40%. 78% is getting pretty good. 86% is about what you should consider 100%. This is volume percent mineral. But you can get less than half of that. And it varies all over the tooth, so it makes it difficult to work out where it stops. And you can make really nice pictures. But if you don't have microradiography, you can use polarised light microscopy to do these sort of studies as well. It's full of carbonate, 60% more carbonate, so it's more likely to dissolve. The ultrastructure is strange. These lesions, this enamel does not look normal when you look at it under SEM. The surfaces, so this is this area here, which doesn't look that affected, full of little holes, which might explain some of the sensitivity issues that some kids get when the tooth isn't broken down. It just looks a bit funny. But it's like a colander that allows a whole lot of product to get in there. It's certainly, these holes are bigger than bugs, 6 to 8 microns across, a lot of them. Bugs might be 1 micron. And there are some studies out of the UK and Sweden that show bacteria in dentine underneath what is intact hypomineralised enamel, and no one could work out why it got in there. And this is probably one of the reasons why. The enamel itself, there's a lot less mineral, the rods are thinner and there's bigger gaps in between them. Looks like when you fracture these teeth, and these aren't etched at all, looks like corrugated iron. So there's, and I've been told by enamel experts, a core of enamel rod does not exist. It was a myth. But these look like the core's been pulled out. So there's a surface and then a middle part, and the middle part comes away when you fracture it. Normal enamel doesn't do this. And big gaps in between with this sort of amorphous crystallisation in between. Can you remin it? Yes. So this is the lesion here. We covered this in varnish, remineralised this, and if we just looked at, say, 50 microns, we got 66% more mineral. But you've got to surface treat it, and that's the issue that we're working on. So here, what Felicity did was very gently disc it with a Softflex disc to get rid of the surface layer. And so we're working on how we can avoid having to disc the surface, because obviously the surface layer is the best part of the tooth. But this was a proof of concept that can you actually remineralise this enamel that's full of protein? And the answer is yes. So 300% increase in hardness when you compared remin to not remin. Can you infiltrate it? So this is the commercial kit, the Icon kit. This little proximal adapter, so that slips down in between the tooth and you can infiltrate into proximal white spot lesions. This is a smooth surface adapter. The white is the hypomineralised lesion. This is the infiltrant. So very erratic. And the infiltration, so here you're getting down to 500 microns, probably 700 microns there. If you can't predict where it's going to go, you've got to have great caution about using it clinically. So we got 60% increase in hardness. So it was, even though with remin we got 300% increase in hardness. So it's a quick way of trying to improve the physical characteristics, but would I be using it at the moment? No. So again, we used different types or different ways of looking at remin, but again, erratic variables. We got, in another study, small increase in hardness here. This is running from the cusp tip down to the cervical. So when you look at hypomin enamel, what are the problems and what are the issues? There's less mineral, so you've got to try and get more mineral in there. It's soft, so you've got to try and protect it. It's porous, so you've got to try and decrease that porosity. And it's probably one of the justifications of getting glass ionomer onto the teeth, because hopefully you'll fill up some of those pores. There's more carbonate content, so you've got to try and get calcium phosphate fluoride in there. So if it's dissolving, at least it's being replaced with high quality mineral. The structure's less organised, so you can't rely on bond strength. But you can get quite a decent thick surface layer. And some of our surface layers we measured were up to 100 microns, which is a tenth of the thickness of the enamel. And interestingly, we never found, out of the hundreds of teeth we've chopped up, there's never been one that's had the cervical enamel affected, so the cervical third. So if you're looking, in some of these kids, it's amazing how many of these kids are missing fives. If you're looking at maintaining the tooth and using overlays, you can go to the cervical, if you can get the tooth erupted enough, you can go to the cervical third and know you'll get normal bond strengths. But it means you've done a 2/3 crown prep on a 9-year-old or an 8-year-old, which is probably not something you really want to do a lot, but it's an issue that we probably don't really understand why it occurs, but it's in all likelihood to do with enamel thickness. That as the enamel tapers off towards the cervical margin, the ameloblast is less stressed, and so it's less liable to be affected by some sort of insult. That's our theory. It hasn't been tested yet. So I might leave it there. I've done my hour and 5. I could go for another 3 hours, which would bore the hell out of you even more. So I'm happy to take questions. Hopefully there's been some information there of value, but thank you for being quiet and not throwing anything. So thanks very much.
So do we have any questions?
What we... Yeah, it's sort of it's a double-edged sword that you want surface development, but you don't want to then create like a bit of glad wrap over the top that stops anything else. We do thumbprint GRCs on them, but often the hypomineralisation's on the smooth surfaces as well. So that's where you hit them with the tooth mesh as well. GRC is very porous. So one of my studies that's just being set up at the moment is, can we actually remineralise through the GRC? I didn't show you those images, but Felicity's got some great images of remin under Fuji sediment. And you know, some people say, oh, it's from the GRC. Glass enamel cement doesn't have calcium. So it's either the GRC is leaking like anything and you're getting salivary calcium, or it's actually going through. So it's a little study. But the other thing we occasionally do are prophylactic stainless steel crowns, non-prep. Probably more frequently now than we used to. If we think we'd like to hang it like a really young kid, 6, 7, even if you're extracting the teeth, that's normally 8, 9, 10. And sometimes, say, if they're class 2 Div 2s, it might be 11, 12, 13. We'll do like a Hall technique. There's the Hall technique hit here. Okay, you know, minimal prep, as in a bit of scooping out if we can, and then fill it up with GRC, ram it on, get the kid to bite like anything. And so they've got 4. We do a jaw at a time. We wouldn't do opposing teeth because they're non-prep. Right? I'll go to surgery like this because you jacked them open a centimetre, but they'll come back in 2 or 3 weeks and that's gone. Maybe don't do it in dolichofacial kids. Those. Yeah. Oh, look, and it's often the 9, 10-year-olds who are the worst affected because they've had a series of people have goes at them. They won't go back to him, so they take them to someone else who does exactly the same thing to them. And they've been told they're liars. Because they're going, no, you're numb. Well, you're numb. And so what they're thinking is, oh, why am I lying? Why? So it's very confusing for children. And if they're really young, they don't have rational thought, so it's even worse. Yeah, it's a problem. GA is the answer.
Okay, thanks, David.
Pleasure.
Yeah, at this stage, I'd like to thank David for his most interesting and informative talk. Not having done much children's dentistry myself, I found it very difficult to keep up with that. I think I'll stick with implants. They sound a whole lot easier. But look, I really do appreciate you coming tonight. I know you went out of your way. I'd like to give you something appreciation, and thanks very much.
Thanks very much.